Thank you for that introduction, and thanks for the opportunity to speak today. My goal is to give you a little bit of a window into, I think, some wins in our field, which are a bit overdue and hopeful for our patients. And I'll kind of jump around a little bit and cover topics as we go. I have no disclosures. So this is my outline. We're going to start by talking about rational drug design for low-grade IDH mutant gliomas. We've had some really big developments here in the last 2 months. And then we'll talk about more incremental advances in the space of glioblastoma. And we'll talk a little bit about some new targeted therapies for papillary craniopharyngioma, and then we'll wrap it up by maybe giving a window into where I think meningioma diagnosis is going in the next couple of years. So I'll start by making the point that IDH mutant gliomas, we used to sort of say, oh, all low-grade gliomas are kind of in one box, and some of them are IDH mutant and some of them are IDH wild type. That's really not the case anymore. IDH mutant gliomas are a totally separate disease, and you can see why. So, these two curves depict the survival of patients who, in red, have IDH wild type, in this case, grade 3 astrocytoma, and in blue have IDH mutant grade 3 astrocytoma. So this one difference between what in the past we would have called similar tumors results in that difference in outcome. So these are not the same disease. So in the most recent WHO guidelines that came out about 1.5 years ago now, this is a standalone category. And I'm showing you here a couple of things that I think are worth knowing. The first is, of course, we determine IDH mutation, and then we have this kind of overall category of IDH mutant glioma. But then the next thing is we want to know the 1p19q status that defines oligodendrogliomas. And I'll make the point that oligodendrogliomas do not become grade 4. In green, I'm showing you here some survival numbers that might be different from what you've heard before. This is what happens when you look at only IDH mutant tumors. And so I would argue that these are sort of more accurate, updated survival numbers. And they're actually relevant to the rest of my talk, because if you look, a grade 2 oligo doesn't even reach median survival at 2 decades. A grade 2 astro reaches median survival between 14 and 15 years. So these patients live long enough that everything we do to them matters, and ultimately, there are downstream consequences. The other thing I'll point out is we can now upgrade a tumor based only on the presence of a CDKN2A/B mutation. This is also called P16. So if both copies are lost, irrespective of histology, it becomes a grade 4 astrocytoma. And again, notice that I'm not calling this a glioblastoma. So this is an IDH mutant grade 4 astrocytoma. It's not called a glioblastoma because look at the outcome, right? It's not the 15 months you expect. So what does IDH mean? It's isocitrate dehydrogenase. It's an enzyme that converts isocitrate and alpha-ketoglutarate, and there's actually 2 of them. One is in the cytosol, one is in the mitochondrion. And IDH1 is in, well, now I can't remember. I think IDH1 is in the mitochondrion and IDH2 is in the cytosol. So when not mutated, so in its normal state, this enzyme is only activated in states of hypoxia and produces the L enantiomer of this molecule 2-hydroxyglutarate. Whereas when mutated, it becomes 1, constitutively active, and 2, produces the D enantiomer, which actually is not present in normal tissue. So here you can see this is mass spectroscopy from an IDH mutant human tumor, an IDH wild-type mouse tumor for some reason, and then an IDH wild-type human tissue. And you can see that this, they're implying D2-hydroxyglutarate, is just not present in normal tissue. So what does it do? It actually decreases the ability of cells to pull off methyl groups from histones, and so it results in a hypermethylated phenotype. And so by this epigenetic mechanism, it affects the expression of thousands of cells. So this one quote-unquote oncometabolite, because it's a metabolite of the tumor, is actually driving tumorigenesis. So this is a great target for therapy. So well, not we, but the folks at Sloan Kettering have developed an IDH inhibitor. And this is one of the early trials. So you can see 3 kind of patient examples, and they're doing volumetric measuring over time, which is depicted here in the graphs. And then the dotted line indicates the start of this IDH inhibitor, which is called evositinib. And you can see pretty clearly the change in the trajectory of growth. So this was very exciting. And then they did a phase 1, phase 2 trial. In this trial, they allowed both high and low-grade tumors. And you can see in the waterfall plots on the left that they really had more success with non-enhancing tumors, which are presumably lower grade. So enhancement, of course, means that the tumor can perform neuroangiogenesis. And then they did this really nice control. We're seeing more and more of these target validation controls in neuro-oncology, which I'm really happy about. They showed, first of all, in the blue line that this once-a-day medication remains, at reasonable levels in the serum for a full 24 hours. But more importantly, what you're seeing in the red is that oncometabolite I talked to you about, the D2-hydroxyglutarate. And you can see the red is a patient with an IDH mutant tumor. The green is a patient without a tumor, without a mutation. So basically, you have shut down production of this molecule for 24 whole hours. So that's very exciting. And then they went on and did a phase 3 randomized, blinded, and placebo-controlled trial. They only allowed IDH mutant low-grade tumors because of these data here. So you can see that enhancing tumors, we sort of think of them as over time, if they start out, mostly epigenetically driven, they eventually do acquire, DNA mutations that are driving disease and become less amenable to treatment. So we focused here. They included oligos and astros, grade 2 only. So the design was to take patients who had had surgery at least 1 year and no more than 5 years prior, and no subsequent treatment, no radiation or chemo. And then it was a crossover design, so if you were on the placebo group at progression, you would get the study drug. And these are the patient characteristics. There's not really much here. I think it's exactly as you would expect. The couple things I'll point out is it was about evenly split between oligos and astros. A fair number of tumors had at least 2 centimeters of measurable disease. The other thing down here is just kind of a nice demonstration. So this R132H, this is the canonical mutation. So when you see somebody saying that a tumor is negative for IDH by histology, they have an antibody for just this mutation, and that's what they're testing. In patients below 55, you do need to do PCR to test for these other ones, which are more common at that age group. And here's the result. This was published a month and a half ago. So progression-free survival, 6-month progression-free survival was the primary outcome. And you can see this really nice effect. And what I will say is this is progression as determined by radiographic criteria. And so we have these very strict and maybe a bit too strict and rigid radiographic criteria. So if a tumor or if an area of T2 flare hyperintensity grows by 25% or more, then we're calling it progression. But what I think really was the kicker was this. So this is time to next intervention. So this, I think, better reflects the clinician's judgment about what's going on. And so you can see, even though technically folks are progressing here, it seems like the clinicians weren't that worried about it because they did not proceed to the next treatment. So now you've taken these patients who have, in the case of Astro, 15-year, in the case of Oligo, greater than 20-year survival, median survival, and you have put off radiation for 2 to 3 years at least. The data are still maturing. So that's a really big deal because when we do these toxic therapies, there's a downstream cost. They're great treatments, but if you've ever met a patient that was treated with radiation, to a large field 20 years ago, you'll know what I'm talking about. More and more, we're learning that these are diseases where we need to try to hold off on these toxic treatments for as long as we possibly can in order to improve overall morbidity. If you think about morbidity as area under the curve, if you start that morbidity later, you've had a huge effect on somebody's quality of life. So this, in my mind, IDH inhibition becomes first-line postoperative therapy in all low-grade gliomas. It's a bit hard to get right now. There's an older drug. The study drug here was vorasidenib. This is the second generation. The first generation is easier to get, but that should change in the next year. So that's kind of our big story in 2023. I'll stop and take questions if there's any, and otherwise I will move on. This is the subgroup analysis just to show you that it wasn't really, the data were not driven by any particular subgroup. What I thought was interesting was here, if you look at this last category, it did seem that actually larger tumors benefited more, which you almost never see in neuro-oncology. So I found that pretty striking, but that was the one thing that jumped out at me. And then in terms of adverse events, so this is, IDH inhibitors are taken daily, but they're really pretty well tolerated. You get some transaminitis, a little bit of a fatigue, a little bit of occasional nausea, but really these are very well tolerated medications. So the trial was stopped in June, of this past June. All of the patients on the placebo arm were crossed over, and FDA approval is pending. Okay, so that was exciting. Now we have to tamper down our expectations a little bit because we're talking about glioblastoma. So I want to just go through 5 not so new things just to make sure everybody has heard about these things. These are sort of the big developments of the last 5 to 7 years. So there's a phase 2 trial now that says that more Temodar is not better. We know that pretty definitively. There's a couple of well-done retrospective trials, but this is sort of the definitive prospective trial. And you can see that even numerically, patients who got less Temodar did better, although that wasn't significant. And it's not clear if that's true in low-grade disease. For MGMT methylated GBM, so remember that MGMT is an enzyme that pulls off the alkyl groups that are put on the DNA by Temodar. When it's expressed, the tumor is less sensitive to Temodar. When it's not expressed, it's more sensitive. And so when the promoter is methylated, the enzyme is not expressed, and so the tumor is more sensitive to Temodar. So in MGMT methylated GBM, if you use 2 alkylators, it is better than 1. So that was the CTEG study out of Europe. Catnon is an important trial that showed that there really is minimal to no benefit to concurrent Temodar. So anyone in the hospital who has an infection, I typically get calls like, well, should we delay radiation? And my answer is always no, just start radiation and skip chemo, because there's probably no benefit. And the Optune trial, so EF14, showed that tumor treating fields actually cause greater improvement in overall survival than chemotherapy. And there's also a time dose effect in the post-marketing trials where if you bin patients in 3, 6, 9, 12 months of use and so on, there's increasing benefit for the longer the device is worn, which makes sense. And the last big development was that short course radiation is now standard for elderly patients or patients with low performance status. So what's actually new as of this year? I get a lot of calls lately about this NBC article, which says that there's a doubling of survival time with this new treatment. So people are obviously very excited. So what is this? So Survax-M is a peptide vaccine. It's multivalent, so it's targeting multiple splice variants of this protein called survivin. It's a very oddly named protein. Survivin is overexpressed in glioblastoma. It's overexpressed in other tumors as well. And it does a couple of things. It's an inhibitor of apoptosis. It also results in increased chromosomal instability, so accumulation of mutations, which GBM does a lot of. And I don't fully understand, the development of this vaccine, but I'm told it's, been developed in a pretty clever way to circumvent immune tolerance by activating mid-affinity multiclonal CD8 and CD4 T cells. I told you that it's multivalent, so that sort of takes away a potential escape mechanism for the tumor. So, you can't just favor another splice variant to get away from this vaccine. It's hitting all the major splice variants. And it stimulates IgG recognition of cell surface survivin. So you can see here on the depiction of this cell, there's survivin in the nucleus, in the cytoplasm, and then this is supposed to be the cell surface. So there's survivin on the cell surface. So you're getting an adaptive immune response against cell surface expressing cells, survivin. So the trial that was reported in the NBC article was a phase 2 study. They were interested in 6-month progression-free survival. They had 63 patients. It was a single-arm study, and it was performed at 5 centers. And this is a depiction of their protocol down here. So basically, they would start with the first vaccine dose. And by the way, this is subcutaneous, so it's not delivered intracranially. The first vaccine dose was after radiation prior to initiation of adjuvant chemo. They did 4 doses every 2 weeks, then there was a gap, and then there was maintenance dosing every 3 months. The eligibility criteria are listed here. Nothing really jumps out at me. I think it's pretty appropriate. So again, target validation is increasingly being required in our trials because we've had so many failures where we do a phase 3 trial, like with an EGFR targeted antibody or something, and then people are saying, well, did it get in? So here, what we're showing is that as you give increasing numbers of doses of this peptide vaccine, you get increasing antibody titer of survivin-specific IgG. And later in the study, we'll divide people into responders and non-responders, and they put that line right there, sort of arbitrarily at 30,000. And you can see that, a little over half of patients are developing this immune response. Then they went further and they said, okay, we have the antibodies, but are they doing anything? So they took patient whole blood, derived monocytes, put them in culture, and then they challenged them either with peptides from, this is CMV, EBV, and influenza, or different splice variants of survivin. And you can see that there was a survivin-specific response as expected. So this is nice validation that yes, not only are you generating the survivin-specific IgG antibody, that's also resulting in an ability to mount an immune response when the immune system is presented with the survivin antigen. So they didn't plot their primary outcome, but this is it. So 6 months following diagnosis, 95% of survivin-treated patients were progression-free. That's a lot better than we're used to. Of course, this was an uncontrolled study, so we're looking at external controls, and I think if there's people watching from the MS community, they'll have something to say about that. But irrespective, I think it's a big enough effect size that it's really not in much question. If you start the clock at the first dose of survivin, which remember happens after chemoradiation, so a couple months after diagnosis, then you get a 6-month progression-free survival of 54%. And again, if you compare with a similarly timed external control, their number was 37. So kind of no matter which way you slice it, there is an effect there. But actually, subsequent data were more convincing to me. Here, I think what's worth seeing is the overall survival numbers. This was not their primary outcome, but it's what people are interested in. When you first look at this, there's kind of like a wait a minute moment because you see an overall survival for unmethylated GBM of 15.6 months, and you think, well, wasn't that the Stoop number just about? And it was. But this number is starting from the first vaccination. So it's actually, about 3.5 months after diagnosis. So this number actually is closer to 19.1 months if you measure it the same way that we measured it in the original trials. And then the other thing to point out is the Stoop trial didn't just contain unmethylated glioblastoma, it contained both. So really, these numbers are undeniably better than what we've had in the past. Maybe they're similar or depending on how you combine the data, maybe a little bit better than tumor treating fields, which I've told you are now standard. They should be offered to every patient. Interestingly, this trial and also its successor trial that's currently ongoing does not allow tumor treating fields. And I think that's a major liability of the trial because you sort of have to convince people not to do this proven therapy. And also, tumor treating fields, there's emerging data, I don't have a slide on this, but there's emerging data that they actually result in increased expression, cell surface expression of nuclear proteins. So they somehow permeabilize the nuclear envelope. And that apparently results in a much more robust immune response. So we had a study it was presented at the Society for Neuro-oncology about 2 years ago. And they had recurrent GBM, and they just said, we want you to use tumor treating fields and get Pembro. And they had, I think, out of 11 patients, 6 of them had a partial response, which we define as 50% reduction in enhancing disease. That's pretty big. And so that's, an area of excitement. There's a trial coming in that space, which I intend to open here. So anyway, to me, this is probably the biggest deficiency of the study. So then they're showing you again this same figure here to remind you, and then they're dividing patients at this 30,000 IgG units. I don't know what the units are. And they're saying anyone that, by this point here had less than 30,000 IgG was a non-responder. And if they had more, then they were a responder. And then you can see here the survival by subgroups. And basically, whatever your subgroup was, you did better if you were mounting an immune response. And that's actually better depicted here. So here's a Kaplan-Meier curve for overall survival. And in red is the patients that did mount an adaptive immune response. And in blue is the patients that did not, according to their criteria. So here you actually do double survival. So technically, NBC's headline was right. It's a little misleading, but the way I would say it is if you get survivin and if you're one of the, about 55% of patients that mounts an immune response in response to survivin, then you do get twice the survival. So that's a really big deal. This is a signal that we can build on. There's a phase 3 trial ongoing, and I think should be resulting in the next year or two. So I think maybe soon I will have as good news in the GBM space as I just had for IDH mutant. Stop there for a second. Any questions? The next story I'm going to tell you is also, I think, a really hopeful story. This is first-line drug therapy now available for papillary craniopharyngioma. I'm sure folks have seen these patients. They tend to have a rough go, mainly because the location is just very morbid for either surgery or radiation. And that's actually what this study cuts to the heart of. So you might know that most papillary craniopharyngiomas, which are less common than adamantomatous craniopharyngiomas, which I always struggle to say, they have classically a BRAF V600E mutation, almost all of them. And so naturally we have experience with this mutation through the melanoma space where we have had actually a lot of success changing the course of that disease with targeted therapy against BRAF V600E and also immunotherapy. So can we apply that same strategy here? So what is a BRAF V600E mutation? So you see here this mutated BRAF V600E monomer, and you see here the natural state. So in the natural state, you have 2 RAS molecules and then a BRAF and a RAF1. And these guys, in response to cell surface binding, have to heterodimerize. And then when dimerized, they stimulate signaling of MEK and ERK and proliferation. If you have this V600E mutation, you don't need to dimerize, you don't need a cell surface signal. This thing is just active, and it's sort of driving the signaling. And so when we first figured this out, the first approach was, well, great, let's block it. And so we have these drugs that are inhibitors of BRAF, And that was a really bad idea, it turned out, because what actually happens when you do that, for reasons I honestly still don't fully understand, when you shut this down, you actually increase the activity of the endogenous system. You increase signaling through the endogenous pathway, and the tumor grows. So you have to shut down both the mutant protein and the downstream target. So that's why we do BRAF and MEK inhibition together. So we learned that from melanoma. This was already known at the time of this study. So the study question was really simple. Can we do a single-arm trial and look at overall response rate in the setting of targeted therapy? So the eligibility criteria were tumors had to be newly diagnosed, at least a centimeter in size, but any extent of resection, 18 plus, and no intracranial hemorrhage, which actually is a bit limiting for these surgeries. And it's a single arm. There were 16 patients, and they were just interested in objective response by volumetric criteria. And here's the results. 94% of patients had a partial response, which is defined differently in this space. It's 20% reduction in size, or a complete response. So shown here in this waterfall plot, all the patients but one, so 15 out of 16, had a pretty robust decrease in the size of their tumor. So this is better than anything we've seen before in this space. And if you follow the melanoma literature, you might know that BRAF inhibition, BRAF-MEK inhibition, it works great for a period of time, and then it sort of stops working. And I sort of think of it as 6 months. But in this space, the effect was durable to 18 months. Nonetheless, these are not easy medications to take. There are a fair amount of toxicities. Patients don't love them. And so I don't think of this as like a long-term strategy. And I don't think the authors did either. But here's the key point. So for example, 14 tumors abutted the optic chiasm before treatment, and afterwards only 6 did so. So that's how we're thinking about this. This is a neoadjuvant therapy intended to improve surgical outcomes, improve the ability to target the tumor with radiation. So in my view, this is now first-line therapy. This neoadjuvant therapy becomes first-line. Any questions there? All right, I'm going maybe a bit faster than I intended, so we'll be done early. The last thing I want to talk to you about is sort of the big picture view of where I think meningioma treatment is going, and unfortunately, we're still stuck on diagnosis, so it's where meningioma diagnosis is going. This is meningioma grading in the present. I'm showing you grade 1, grade 2, grade 3, based on their diagnostic criteria in the middle column. So, the big things are brain invasion and mitotic rate. If you have brain invasion, you're at least a grade 2. Mitotic rate, if it's less than 4 mitoses per 10 high-powered fields, like under the microscope, then you're a grade 1. Between 4 and 19, you're a grade 2, and over 20, you're grade 3. And then there's also these other criteria, which if you have 3 of them or more, that's enough to bump a grade 2 to a grade 3. So here's the frequency of each grade in the overall meningioma population according to current diagnosis. And here's the 10-year overall survival. So I put this on here because just to make the point that grading actually really does matter. Meningiomas are not benign, as we sort of frequently say. Some of them are terrible, and I would say a grade 3 meningioma is, in my view, the worst tumor you could have because it just drags on, and these patients, they go through a lot. So, why does grading matter? Grading matters because it dictates treatment. So there's a couple areas here. So this is our algorithm for treatment. If you're grade 1 and you get a gross total, then we don't do anything else, we observe. But there's 2 areas where we're not quite sure what to do. There's ongoing trials, but the question remains unanswered. If you have a grade 1 meningioma and a subtotal resection, should you treat? We don't know. And if you have a grade 2 meningioma with a gross total resection, should you treat? We don't know. So here really is where most hemming and hawing is done in a tumor board. If you have a grade 2 and residual tumor, those folks are going to get radiation, and grade 3, whatever the extent of radiation, is going to get radiation. So this is why getting a better diagnosis is important, because I think, all of us have patients we can think of where we thought we knew what the tumor was going to do and we're very surprised, which can go both ways. And so this is, in my view, probably the most important meningioma paper recently, although it's almost 2 years old now. What they did was they took a collection of high-risk cytogenetic and molecular changes that had been reported and well-validated. And they very arbitrarily came up with a scoring system. You can see it's not complicated. Basically, for each feature, you get a point. If you have 0 or 1 points, it's grade 1. 2 or 3 points, it's grade 2. More than 4, it's grade 3. And this was arbitrary. This is not a validated, algorithm, because there's really no data to do that with. They did include mitoses as a lone histologic criterion that was included in the grading system. And what they did was they took a large population of tumors for which they had all of these data, and they basically regraded them. So on the left, in Roman numerals, you're seeing the WHO grading. And on the right, in Arabic numerals, you're seeing the integrated diagnosis, so with this scheme. And then you can see how things moved around. So most grade 1 diagnoses are correct. A small number are probably more like grade 2. And then there's this surprising number that are actually grade 3. I think the two big takeaways for me from this figure are, one, that we are really terrible at diagnosing grade 2 meningiomas. You can see that we're wrong 2/3 of the time. So 1/3 of the time, it's actually grade 1. 1/3 of the time, it's actually grade 3. And that leads to the other big realization that I had reading this paper, is that grade 3 meningiomas really are not rare. We think of them as rare, but maybe they're not. And that, I think I'm biased as a neuro-oncologist because I see the meningiomas that misbehave, but it does seem like I see more than I ought to. So how can we sort of think about this and do a gut check to figure out if this regrading actually more accurately depicts clinical behavior or not? So I think they did a really good job. What you're seeing on the left is they've taken a bucket of grade 1 tumors according to WHO criteria. And so that overall population is in gray. And then they've broken it down into they regraded all of those individual tumors according to molecular criteria. And then those are depicted in color, with blue being grade 1, green being grade 2, and red being grade 3. So now all of these folks here in red would have been called, according to WHO criteria, a grade 1 meningioma, but look at their behavior. So I think this strongly supports the premise that the integrated diagnosis outperforms what we're currently doing. And think about the implications. So these folks, if they had really, actually, regardless of the extent of resection, if you knew that this is the category they were in, you would offer them radiation after surgery, and I'm betting most of them didn't get it. So this is practice changing. And then you could also think of it the other way. So here you have the population of WHO categorized grade 2 tumors. So the overall population, again, is in gray. And then again, you take that overall population and you break it down by molecular integrated diagnosis into grade 1, grade 2, or grade 3. And so, yeah, we know that there's going to be some misbehaving tumors here, but the big surprise is, look at these guys. So a lot of these folks would have received radiation after surgery and according to this plot, really not needed it. So that's how this is informative, and I do think that that's where we're going. The next WHO update will probably be in the late part of this decade, and I feel pretty confident that this will be included. So meningioma, we're quite a bit behind even the glioma space, which in itself is behind the systemic oncology space. But I think within the next 15 years, we should be getting to treatment. There's only a couple meningioma treatment trials, and I think nothing really worth getting too excited about at this point. So, all right, that is everything I wanted to talk to you about. Happy to be part of the group. Please reach out anytime. This is my cell phone number. Call or text for any questions, and I'll take questions with that. Yeah, David.
I'll migrate to a microphone here. So great talk, Alipi. Last part about meningiomas really just had me wondering, all the time, general neurologists, we find an incidental meningioma, and I guess the majority of those patients aren't necessarily plugged into neuro-oncology, don't always even get some sort of biopsy, but just with all that data, that had me a little bit worried. So I guess what do you suggest it would be the threshold for basically referring to neuro-oncology or neurosurgery for biopsy?
That's a great question. So always clinical comfort is sort of the ultimate guide. If something about the case makes you uncomfortable, I'm happy to see the patient. The guideline for surgery, so when should you get tissue? There's really 3 criteria. If the patient is symptomatic, if the tumor is growing, or if the patient wants it out. Believe it or not, that's a valid criterion for doing surgery. And the way I approach it, when I see an incidental meningioma, typically they're not symptomatic because it's incidentally found, or even if they have minor symptoms on exam, I will watch it at first. I'll do a 3-month interval scan, then a 6-month, then a 12-month. And then I typically do a couple 1-year scans before I start thinking about going out to 2-year scans. At 5 years, I do that. And then at 10 years, I kind of stop looking if they're not changing. But if at any point they're growing, I think it deserves a histologic diagnosis.
Great, thank you.
Am I supposed to check from the chat, or how does this work?
Maybe.
Okay.
Just a follow-up question to
Yeah.
that. So, are there imaging characteristics at the time that you first see a meningioma, and you don't have the benefit of serial imaging, that may tip you off that this is more likely to be a higher grade meningioma? It's going to behave differently.
Sure. So for those at home, the question was, are there imaging features at initial diagnosis for meningioma that would be indicators that you would have a more aggressive tumor on your hands? I would say anytime I see parenchymal edema, that's for me sort of an indicator that I need to interrogate this tumor with tissue. There are some meningiomas that without invasion of the brain will still cause edema, but there is also a lot of meningiomas that will cause edema by invading into brain tissue, and that's a grade 2 feature. Also, if there's parenchymal edema, typically you're going to have some sort of symptom, depending on location. So that's one. Rate of change is another. If I see calcification, of course, that tips me the other way, and I become a little bit more reassured. And then, context is also dependent. So, not all dural-based tumors are meningiomas. There is a differential diagnosis. Most of them are, but if you have a patient with a lymphoma or some sort of, blood abnormality that's suspicious, maybe a monoclonal antibody, if you have a patient with any systemic cancer, I wouldn't assume. So I would at least, think about it and, not necessarily go straight to surgery, but definitely get a short interval MRI. Yeah, please.
Follow up to that, are there any advanced imaging, perfusion, dynamic sequencing that you'd recommend on your serial follow-ups, just to rule in or out the aggressiveness of the tumor?
So the question was, are there any advanced imaging modalities that I would obtain on a follow-up imaging for meningioma? And I personally wouldn't. I don't think it's that helpful. If you're suspicious about something like a solitary fibrous tumor and you sort of want to look for other spots, then you could do a dotatate scan or just a neuraxis survey by standard MRI. But I don't really think of advanced imaging as helpful for me, and I might be ignorant of changes. So if a radiologist felt differently, I would defer.
I guess I had another question as
Yeah.
well. So, pardon my ignorance of neuro-oncology here, but the first part where you were talking about with gliomas and the mutant gliomas having better survival, was that because they allow for a drug target?
No.
that was independent?
Yeah, so that is an independent effect. It's inherent to the tumor. So if you don't treat it and observe its natural behavior, it's going to grow more slowly. If you do treat it, it's going to be more sensitive, and this is IDH mutant low-grade glioma. It's going to be more sensitive to radiation and chemotherapy. And so all around, they behave differently, and it's just because they're built differently, right? These tumors, especially when they're low grade, they're driven by epigenetic changes. Some of those changes are not stable. You can hit the tumor in ways that will really damage it. Whereas when they've accrued a bunch of, actual mutations that are, now not going to change, which is kind of more thought to be the pathway for IDH wild-type tumors, then treatment is less successful, but also the tumor is inherently, just grows quicker. So when I see a low-grade IDH wild-type tumor, actually I don't see that many of them, but I always am a bit more worried about that one. So like these guys I might image every 6 months. IDH wild-type, until I really have a period of stability and I'm reassured, I'm imaging every 4 months or so.
Do you see differences in the pediatric versus adult population?
Yeah. Yeah, the question was, do we see differences in pediatric versus adult tumors? The answer is yes. The pediatric tumors seem to be, hope I'm not casting too broad a generalization, but I think that they're better behaved. And that's true for low and high grade tumors. Well, at least they're better behaved in adulthood. Yeah. Yeah, please.
Do you ever see the technology applied to the IDH mutant being applied to wild type? Do you see there being a way to translate that?
So the question was, can you apply the IDH inhibitors, can you utilize those in an IDH wild type tumor? And the answer is no, because so in an IDH wild type tumor, this pathway, which you're targeting with the medication, does not exist. So this doesn't exist in normal tissue. And IDH inhibition, so inhibiting like the normal IDH signaling pathway has never been shown to be beneficial. I guess in fairness, I don't think it's been studied, but I wouldn't expect that that would be beneficial. All right, well, thanks everyone.